Assalamualaikum warahmatullahi wabarakatuh and good day to all. Today, we would like to invite you to interesting seminar consists of three main topics which are: first, public health impact of legalizing recreational cannabis use, the US experience; second, integrating public health in planning for climate change policy; thirdly, the role of telehealth in COVID-19 outbreak. Enjoy! First, we would like to present you all with the seminar of public health impact of legalizing recreational cannabis use, the US experience. Before we discuss regarding the public health impact of the cannabis legalization in the US, let's have some introduction regarding the legalization of cannabis worldwide, especially in the US. Cannabis is globally the most widely used illicit drug under international control. In 2017, it was estimated to be used by 188 million adults worldwide, or 3.8% of the global adult population. The route to legalization of adult use in the US began with citizen-initiated referendum that legalized the medical use of cannabis, initially for serious illnesses like cancer. Then, it became progressively under liberal regulations that allow the supply of cannabis by retail and commercialization. Legalization allowed the establishment of the legal cannabis industry that has an interest in promoting cannabis use, and unlike the policy that legalized medical cannabis use prior, it allowed adults to use cannabis for any purpose. What are the logic behind cannabis legalization? Cannabis is common among young adults and causes less harm than alcohol, tobacco, and opiates. Cannabis use is a criminal offense that causes more harm than cannabis use itself, because some users are arrested and receive criminal records. It gives economic advantage to the government through the taxation, and criminal laws give unfair treatment and judgment to cannabis users in minor populations such as African American and Latinos. Legalization of adult use is a better social policy than criminalization because, first, it eliminates the illegal or the black market. Second, cannabis use can be regulated to minimize adolescent access and protect adult cannabis consumers. For example, by controlling the tetrahydrocannabinol content of cannabis products, such as reducing level of contaminants, fungi, heavy metal, and pesticides found in illegal products of cannabis.
Okay, my friends Naim have explained about the logic behind the legalization of cannabis use. Before we go deeper into what are the public health impacts attributed to the legalization of cannabis use, we have to know what are the acute or chronic health effects of cannabis use. For acute health effects of cannabis use, first, it may increase the road traffic accident if more cannabis users drive more often while impaired, or if cannabis users who drive use more potent cannabis product. Secondly, more cannabis users may present to emergency department with acute psychological distress and psychotic symptoms if they use more potent cannabis products. And thirdly, the adverse effects of cannabis on fetal development may increase if more women use cannabis during pregnancy, as appears to be the case in the US. For chronic health effects of cannabis use, firstly, it may increase the prevalence of cannabis dependence. For example, there is 9% risk of dependence among lifetime users in the US in the early 90s, and this may increase further as cannabis will be readily available. Secondly, for daily cannabis users, they might have impaired cognitive performance that appears to be reversed by abstinence. Adolescents and young adults who are regularly intoxicated during their schooling might have poor educational attainment. Thirdly, the daily cannabis use is associated with an increased risk of psychotic symptoms or a diagnosis of schizophreniform psychosis. Fourthly, for heavy cannabis users, they can develop a hyperemesis syndrome with severe abdominal pain and cyclical vomiting. This syndrome is more often reported by daily cannabis users in the absence of other medical cause. Next, for heavy cannabis users, particularly those who smoke the cannabis, they might have increased risk of cardiovascular disease, especially in young, heavy cannabis smokers. Middle-aged men who have had a myocardial infarction may experience angina and recurrence if they smoke cannabis. Finally, for cannabis users, there are reports that they develop symptoms of cough, sputum and wheezing than persons who do not smoke cannabis, and these symptoms remit if they quit. However, there is no association between the cannabis use with the development of chronic obstructive pulmonary disease.
Thank you very much Dr. Naim and Dr. Ehsan on the background of cannabis legalization in US and the adverse health effect that may arise from the legalization. Ladies and gentlemen, monitoring public health impact of cannabis legalization is very important so that we can understand what are the future cannabis related harm on its legalization. Therefore, we should know what are the potential indicators to be monitored. Monitoring, research and studies should focus on following indicators. First one, monitoring on car crash, fatalities and injuries involving cannabis use should be done. Secondly, surveillance on emergency department attendance for cannabis related problem as well as mental disorders resulting from cannabis use should be also done. And we also would like to know on the pattern of treatment seeking behavior due to cannabis dependent. Is it increasing or being affected by the legalization of cannabis? And when patients come for cannabis treatment for cannabis related problems, we should also take data on why they seek treatment, what are the type and amounts of cannabis use, and what are the routes of administration, and more importantly, we should ask and we should get the data on where they obtain the cannabis, whether it's from legal market or still using the illicit market prior legalization. Apart from that, research should be done to know the effect of cannabis legalization on usage of tobacco and alcohol among adolescents and young adults. And other than that, monitoring should be done if there is any adverse effect on cannabis use in certain age. For example, in US, age above 15 is associated with cannabis use in order to assist their sleep and to control their pain. So we should monitor is there any adverse effect such as increased incidence of cardiovascular disease and cognitive impairment among them. So basically, a good monitoring and surveillance of indicators mentioned just now will assist us to understand the public health impact on legalization of cannabis. With that, thank you.
And now for the second topic, let us enjoy integrating public health into climate change policy and planning state of practice update.
Good morning. Why it's important to understand and act on climate change? Across the world, severe storms, heat waves, wildfires and drought and other extreme weather events are giving substantial impact on human health and well-being. Among these impacts are heat-related illness, injuries and losses due to flooding, exacerbation of asthma, increased risk of vector-borne diseases such as malaria, dengue and waterborne disease. While the causes of climate change are global, health impacts are typically local as they happen where people live, work, learn, play and travel. Due to geography, exposure and sensitivity to health for some local populations are substantially more vulnerable than others. So it is important for a country or region to construct climate adaptive policies with the aim to protect human well-being at the local level. And for this purpose, public health is recognized as a key player to plan policy in order to respond to a less predictable climate. How public health can be a great help towards developing climate change policy? Analysis by US Center for Disease Control (CDC) identified various ways in which ongoing public health activities are actually already supporting climate change related policy making. However, there are still gaps need to be tackled in line with the unpredictable future climate. and as a part of additional measures, enhanced coordination across government agencies and between government and non-government actors was needed. CDC proposed Core Function and Essential Services or CFES model to outline core functions of public health that can be employed as a guide to develop policy and practice responses for the challenge of climate change. And using the same CFES structure, public health role in developing climate change policy can be explained. CFES outlined 3 stages of which will enable public health to assess, plan, and evaluate the policy in relation to health services. First, assessment of the health problems and policy development, and lastly, to do the public health assurance towards the policy plan. And these 3 core functions can be applied to tackle health problems arising from rapid and unpredictable climate change. Public health assessment from climate change point of view consists of 3 categories of data monitoring. Among the data needed to monitor is health status in the context of a changing climate. Firstly, climate and weather data along with their interpretation and downscaling to the local level are essential to develop preventive climate health policy responses. Then, identifying population vulnerability also important part of the assessment. The using of applications such as GIS mapping, social vulnerability index can be used to target emergency response following climate issues. Lastly, monitoring climate-related disease surveillance should be empowered across the country as part of the response. This should consider the ideas of adding non-infectious climate-related diseases such as anxiety, adjustment disorder, and disrupted outpatient medical care into current surveillance system. How assessment help in diagnosis and investigate climate-related illness? Among the key development over the time has been a greater recognition of the dynamic nature of the climate change risk to the health, resulting in modification to risk assessment framework. However, the uncertain nature of the data in developing the model or framework will be the great challenge to public health in response to the climate event. Researchers propose for adaptive management to integrate climate effect into risk assessment framework. And this assessment framework will work in cycle, start with assessment, continuous with planning, implementing, monitoring, evaluation and adjustment, and then return back to the assessment. For example, Health Impact Assessment or HIA has become an additional assessment tool to identify the climate hazards and risks to the health. HIA also can be applied to anticipate how climate change will impact communities as well as to identify waste mitigation or adaptation activities that may result in co-benefits to the population health.
Okay, so we move to the next point, which is policy development. So policy development is the second phase of the core function of the cycle. It builds on the diagnosis from assessment and encompass identification and planning of the action that will be carried out and monitored in the assurance phase. Policy development involves not only government efforts to establish laws, regulation and procedures, but also voluntarily practice of private actors and effort to communicate with the public. When integrated with the 10 essential public health services in the context of climate change, policy development covers first, informing, educating and empowering population toward climate resilience. Second is mobilizing partnership to anticipate and respond to health threats from climate change. And third is development of health policies that support climate change mitigation and adaptation. These are the main points of it. So for the first point is inform, educate and empower. This is to understand the population and emphasize constructive health behaviors and evaluate communication interventions which they offer guidance for advocacy, for adaptation and mitigation strategies, targeted reframing and also using big data analytics. Example in the Leonardo DiCaprio 2016 Oscar acceptance speech, we surpassed the daily average effect on the 2015 Paris Agreement. The second is mobilize partnership. This one is very important. So the coordination across different levels of government and also health in terms of health monitoring, diagnosis and also policy implementation. The second is collaboration of public health with non-health sectors, particularly to share the health-related epidemiological vulnerability and also program monitoring and evaluation of the data. The third is the partnership with private and non-governmental organizations to implement programs to to achieve specific health outcomes. So the coordination across the government should be well integrated together. The third one is the development of the policies itself. So in the mitigation part, substantial research over the decades has involved modeling and quantifying expected economic benefits related to population health from the policies to reduce greenhouse gas, particularly from the power generation, transport, agriculture and household and industrial energy sector. So for example, a global analysis found that health benefit from reduced air pollution alone exceeded cost of reaching the Paris Agreement targets. Example, we can use as HIA. HIA, Health Impact Assessment, has increasingly been employed to identify and quantify co-benefits. However, because HIA are designed for analysis of a program or policy in a particular place with extensive stakeholder management, therefore, they can be time-consuming and data and resource-intensive and can have results that vary from place to place. So it progressed toward the health adaptation planning has progressed from aspirational goal to accomplishment over the decades, and effective adaptation strategies are emerging. To conclude this adaptation, Brukel et al. Note that the public health community generally is unaware of the climate-related epidemiological and assessment tools available, in part due to lack of funding itself.
The third phase of the core functions cycle of CFES model is the assurance phase. Assurance is an implementation and monitoring for the second phase of the model, which is policy development phase, and to complete the loop of the CFES cycle through evaluation back to the first phase, which is assessment phase. Assurance phase involves 4 parts, which are enforcing laws related to climate-susceptible diseases and impacts, linking to and providing care in the context of climate hazards, assuring a competent workforce to respond to climate-related health threats, and evaluating climate health intervention. The first part, regarding the law enforcement, the purpose is for public health agencies to enforce laws, regulations, and other policy guidelines to protect population health. In the context of climate change, for example, are the enforcement of safety regulations that protect from food and waterborne diseases through food inspection, water sampling, and testing. The other examples is vector-borne disease management, like spraying to control mosquito populations. The second part of CFES model is to link and providing care in the context of climate hazards. For example, to deliver physical health care to populations affected by climate change, particularly in response to extreme weather events, which will highlight the need for enhanced public health infrastructures from prevention to treatment. National healthcare systems could also be redesigned to respond to climate health threats by focusing on human resources, facilities, technology, and health information systems. The third part is assuring a competent workforce to respond to climate-related health threats. Currently, there are increasing numbers of universities and schools of public health with climate change centers or climate-related education. There are also efforts to train larger publics, including the development of massive open online courses. Furthermore, cross-fertilization with other fields also occurred, such as with climatology and ecology, and working with local groups and governments to understand the risks to certain geographical areas. The last part of the model or cycle is evaluation. It is a process to evaluate preparedness plans and health communication strategies and identify the importance of linking evaluation to surveillance and a well-trained workforce. For example, the evaluation to review vector control, water treatment, city greening initiatives, and heat wave early warning systems. There are also need for evaluation of interventions to manage drought, floods, air pollution, and food safety. In terms of economic evaluations, climate change to the health events, there are still a lack of robust economic data to inform decision on resource allocation for risk reduction. As conclusion, the health impact of climate change are very much felt and will become even more pressing in the future. To meet the urgent needs for the future, public health community must build on through an updated CFES model with strong governance and implementation, as well as dynamic adjustment activities that will ensure the public health field fulfills its potential as a highly valued and proactive partner in climate policy planning and action.
And for the last topic for this group is the role of telehealth during COVID-19 outbreak, a systematic review based on current evidence.
Assalamualaikum warahmatullahi wabarakatuh and good day to everyone. Today, we will talk about the role of telehealth during COVID-19 outbreak, a systematic review based on current evidence. This systematic review is published in BMC Public Health in 2020. What are COVID-19? COVID-19 disease originated in Wuhan, China, and has kept spreading widely to other regions of the world. Primitive symptoms of COVID-19 contain fever, dry cough, breathing difficulties, and boredom. Elderly people and those with underlying medical problems such as hypertension, heart problems, and diabetes are more susceptible to develop the disease in its form of most intense. The outbreak of COVID-19 is a public health emergency of international concern and has been announced as pandemic by the World Health Organization. A significant factor in slowing down the transmission of the virus is the social gap, or social distancing, that is made possible by the reduction of the person-to-person contact. The best preventive strategies is to avoid being exposed to the coronavirus because there is no vaccine yet at that time to overcome COVID-19 in all countries. To reduce transmission, travel restriction has been appointed and enforced around the world, and most cities has been quarantined. A series of strategies has been proposed for infection prevention and control that may diminish the exposure risk, such as wearing of face masks in mass population, covering mouth and nose with tissue when coughing and sneezing, continuous hand washing with soap and water, or hand sanitizer containing at least 60% of alcohol, avoidance of close contact with others, and keeping true social distance and refraining from touch of unwashed hands with eyes, nose, and mouth. Therefore, telehealth is an effective option to fight the outbreak of COVID-19. So, what is telehealth? Telehealth often used interchangeably with telemedicine. Telehealth is the delivery of healthcare services by the healthcare professionals, where distance is a critical factor through using information and communication technologies for the exchange of valid and correct information. The use of telehealth technology is a 21st century approach that is both patient-centered and protects patients, physicians, as well as others. Telehealth services are rendered using real-time or store and forward techniques. With the rapid evolution of the sizing of portable electronics, most families have at least one device of digital such as smartphones and webcams that provide communication between patient and healthcare providers. Video conferencing and simulated relation systems are also used to provide healthcare programs for people who are hospitalized or in quarantine to reduce the risk of exposure to others and employees. So why telehealth play a role in COVID-19 outbreak? People who are not infected with COVID-19, especially those who are at greater risk of developing the disease, especially elderly people and those with underlying chronic disease, should receive daily care without the risk of exposure to other patients in the hospital. Moreover, under strict infection control, unnecessary personnel such as clinical psychiatrists strongly refuse to enter COVID-19 patients' ward. Natural disaster and epidemic pose make challenges in providing healthcare. As a result, unique and innovative solutions are needed to address both the critical needs of patients with COVID-19 and other people who need healthcare service. In this respect, technologies advance provide a new option. Although the ultimate solution for COVID-19 will be multifaceted, it is one of the effective ways to use existing technologies to facilitate optimal service delivery while minimizing the hazard of direct person-to-person exposure. The use of telemedicine at the time of epidemic conditions such as COVID-19 pandemic has the potential to improve research of epidemiological control of disease and management of clinical case. So what are interesting findings of this systematic review of paper regarding roles of telehealth service during COVID-19 pandemic? This paper recognized 8 studies that presented precious data on telehealth regarding the status of people infected with COVID-19. The first one, Davarpana et al. Done the study in Iran, a case study regarding telehealth of social media platform including messaging web software, WhatsApp and email. They found out that faster rate in teleradiology service delivery, assemble an opinion teleradiology group, create volunteer network coordinator, triage of COVID-19 infection using radiology experts from centers from around the world. So what's the effect of this study? It's eliminated the need to send patients to overpopulated hospitals, provided near real-time consultation from experts located around the country and the world, address the local needs, could solve the shortage on off-site thoracic radiologists, provided consultation in regions with limited access to thoracic radiology expertise, and establish consensus among radiologists through discussion in the online group. The other studies that been done in China, UK by Zai et al. Also done the case study using telehealth live video conferencing and mobile. The key outputs that been found in this study is providing clinician and patient with immediate diagnosis and consultation regarding COVID-19, using wireless remote monitoring of patients, remote multidisciplinary care, education and training of patients, and performing the collection, form and evaluation of patient health data. So, using this telehealth in this study is led to capture, store and process patient medical record, achieve real data exchange, access prevention and treatment guideline and guidance on drug use and management of coronavirus patient. So the other studies done in USA by Reeve et al. Doing cross-sectional study, they use a telehealth by phone call and electronic health records. What they found that by using this telehealth, the triage of patient with phone call, screening or treating a patient with ambulatory care setting, screening or treating a patient in urgent care setting, offering decision support for those in need of testing, repurposing of EHR optimization team to train and user video visit workflow, and telemedicine video visit to outpatient clinic encounters. So all of these key outputs that have been done give them benefit in terms of telehealth services. So the other studies been done in USA and also Canada by Nico et al. Doing also cross-sectional studies regarding social media or other digital platforms including telephone, email and video conferencing, doing the facilitating electronic informed consent, digital assessment tool and virtual study visit, e-consent, remote assessment and telephone and video conference visit, and also provide e-consultation and advice to the health providers. This help in implementing the social distancing and reduce the outbreak of the COVID-19.
So I would like to proceed on a few interesting points that was published on the paper title of the use of telehealth during the COVID-19 pandemic. So one of the study done by the Simcock et al. Somewhere on March 2020, the study was done in UK, US and Italy. This time around they used telephone, video and laptop as a tool for telehealth services, where they use telephone follow-up for multiple cancer patients and also for video consultation. So in this study, they found out that it minimized the risk of COVID-19 transmission during radiotherapy treatment. It also reduced infection risk and the risk of workplace deletion, especially for the cancer patient, and it's also facilitated access to hospital data or to treatment planning systems. Next, there was a study done by Greenhot et al. On March 2020, and the study was done mainly in the US and Canada. So in this study, they used telephone, e-medical record website with video platform as a telehealth tools. They use these tools for delivering allergy services, phone triage as available option in allergic rhinitis. They also provide telehealth visits and service adjustment for allergic sinus disorder and also immunodeficiency. So they found from this study, the usage of telehealth limit the exposure of providers to potentially infected patients, and also preserve social distancing. At the same time, help to visualize any rash through the video conference. This telehealth also reduce the need for the face-to-face visits, and also it is effective for managing patients with chronic conditions. On later date, Cohen et al. On April 2020 did a study in US, but this time around they use apps such as FaceTime, Facebook Messenger and Skype. They use telehealth not for the patient, they use for the healthcare worker, where they use telehealth for meeting to develop staffing plan, conduct billing of patient, and also use for psychological treatment for the healthcare worker staff. They found that the usage of telehealth minimized unnecessary exposure to hospital staff and to patients, and it also minimized the exposure between healthcare workers themselves. Last but not least, there is a study done in China by Zhou et al. On April 2020, where they used the MOOC or Massive Online Course using micro video. As we all know, China is the origin of various social media platforms that can be found nowadays, such as Weibo, WeChat, and TikTok. So in this study, they used telehealth for live broadcast of training video, and also they applied to the communication ability training of the new nurses. Interestingly, they found out that using this telehealth for the staff training, causing easy understanding for the staff, higher satisfaction among the staff, and also it helped to alleviate the lack of clinical nursing teaching resource. So, looking forward about the research potential in telehealth, the biggest challenge for future research in the use of telehealth is probably defining the obstacles and facilitators in health providers and patients. Future research is suggested to specify the effect of telehealth solutions in the efficiency indicators and hospital performance. It is also highly recommended the use of this technology in the field of psychiatry, as it does not require in-person visits. And lastly, other future research can tap into evaluating the satisfaction of patients and providers with telehealth services. As a conclusion, this study provides a comprehensive systematic review solely exploring the potential of telehealth, especially during the COVID-19 pandemic. Previous COVID-19 pandemic scales up exponentially across the world, calls for the expanded use of telehealth as an innovative solutions, and clearly highlights the unmet needs in the world of healthcare systems. Telehealth also has the potential to address many of the key challenges in providing health services during the outbreak of COVID-19. Telehealth also, in other way, can help us avoid direct physical contact and minimize the risk of disease transmission, and finally provide continuous care to the patient. In the long run, I believe telehealth services should be continued as an adjunct to our current healthcare delivery system, despite our progress towards COVID-19 transition to endemic, in order to minimize congestion at our healthcare facility and to ensure better service are given to the patient. With that, I would like to thank you.